Good evening. Can people hear me okay? Terrific. I'm looking at a piece of paper to actually remind myself of my own name. My name's Professor Andrew Zanatino. I'm the Associate Dean for Research for the Faculty of Health and Medical Sciences. I'm filling in for Professor Alistair Burt, the Executive Dean for the faculty, for whom these lectures are named, the Executive Dean lectures. So tonight we're going to have the Associate Dean lecture instead. So, but before we start, I'd like to acknowledge the Kaurna people, the original custodians of Adelaide, the plains and the land that our three campuses at the University of Adelaide have built here at North Terrace, Waite and Roseworthy. It gives me great pleasure to welcome you tonight to the Associate Dean's lecture, and I thank you all for coming out this lovely spring evening. Tonight we're going to actually hear from Professor Bernhard Baune. Professor Bernhard Baune is a Fellow of the Royal Royal Australian and New Zealand College of Psychiatrists. He is Professor and Chair of Psychiatry and Head of Discipline of Psychiatry at the University of Adelaide. He leads a large team of 20 academics, psychiatrists, psychologists, and higher degree by research students. The team's research activities evolve around personalised psychiatry and genomics, clinical experimental psychiatry, neuroimmunology, and the interface between physical and psychological health. Is there anything you don't do? That's the question. So to discuss putting people first, a person-focused approach to mental health, I'm very, very pleased to welcome Bernhard to the stand.
So thanks very much, Andrew, for the very kind introduction, and thanks very much for coming out again to this lecture theatre, which is not the nicest place when it's outside very warm and you want to maybe enjoy a beer afterwards. But before you do so, I want to provide you with some novel insight into psychiatry and where psychiatry as a discipline is heading, not only worldwide but also here in Adelaide through our group, which we work very hard on to advance psychiatry as a field. And psychiatry, I think, has come a very long way. Psychiatry is and mental health more broadly is in the news. It's in the Economist, for example. It's known and awareness around the topics of mental health have risen a lot in the last few years and decades. And I think we have also made some progress in terms of early intervention, understanding early stages of the illness, what type of treatments we might need for patients and people, and also broadened the types of interventions, I think, quite successfully in mental health. However, I think we're still not at a point where we are able to deliver not only diagnosis but also treatments to people with mental issues at a personalized approach. We do that still quite broadly, and what we call apply a wait-and-see approach to await sort of the symptoms and problems and then see what helps and what doesn't, and then kind of move on forward from that. So today's lecture is about the attempt to overcome that obstacle, that major obstacle, which is work in progress, so we're not quite there yet. It probably will fill many people's and academics' lives of several generations to achieve that, but I think I want to outline really the conceptual understanding of this approach and provide you with some first sort of methodological and also results and translate that into clinical practice as we do that at the moment already in clinical trials. So these are my disclosures here, being funded through various national and international grants, but also through pharmaceutical industry and as well as research foundations, especially the two here in South Australia, the James and Diana Ramsay Foundation and the Faye Fuller Foundation, which I like to name here. So a very brief history on psychiatry. So this could be an evening-filling program already in itself. But it started around sort of the 15th, 16th century, where mental health problems described as, with people who have lunatic-type behaviors were actually put into cellars of existing institutions. So it was like a private, and I call this a private approach to mental illness because it was not known publicly, it was not known to the medical field, it was a problem the society tried to get rid of and hide and not see. And that has much changed with the build-up of first psychiatric institutions in the 17th, 18th, and 19th century. And actually in the 20th century, worldwide, what we call the dehospitalization occurred, so that patients who were properly treated or relatively properly treated in hospitals were then released to the community. And these big hospitals, and we have one here in Adelaide, the Glenside Hospital, has sort of witnessed that kind of change over time as well. So it became more public. So what to do with these people? They were in the community, publicly known, and what to do with these people in terms of treatment, in terms of burden of disease, and many studies were actually created around that topic to raise public awareness. And I think that's where we are at this stage, very broadly, that we have an understanding of what the mental illness burden of disease is at in these times, but also have an understanding of what mental illness actually means to individual people. And that's a great achievement. In the last sort of 15 years, I would say, so 15, we had a major sort of breakthroughs, and they are still coming more and more in the area of neuroscience, very broadly speaking. So to understand what's actually happening in the brain, not only at the behavioral level, but also at the neurochemical level and at a level of brain function related to behavior. And this has kind of changed the view that we are now able to understand more, not only the symptoms, but also the sort of underlying mechanisms of mental illness. And in a way, and you will see that as we develop now through the presentation, this has led again to a more individualized approach, because we come to understand that there are individual differences, not only the way we look, the way we speak, the way we behave, but also the biology behind every single of us is individually a little bit different. Now, the awareness of mental illness, as I've said before, has grown a lot, and there's still lots of international activities to show that the burden of illness and the years lived with mental illness and substance abuse is very high. And here you can see sort of the highlights, so to speak, with the highest burden in the United States, in Greenland, Australia, but also in Iran. So this is an understanding of a worldwide problem which has grown over the years. The knowledge on specific mental illnesses like neuropsychiatric disorders in Australia, these are data from 2016, indicating that substance abuse, so the area under these curves here indicates sort of the burden of disease, that these are particularly high for substance abuse disorders, for depression, but also for other illnesses, such as anxiety disorders, schizophrenia, and bipolar disorder. So these types of classifications which you see here are based on symptoms and behaviors, which are assessed by clinicians, and there's no other objective assessment behind the classification of these diseases. And that is going to change as we move slowly along. Now, we have a large group of people, and they could be very different, as you can see here, in terms of ethnicity, of gender, where they come from, what upbringing they had, what education they had. But we are not quite good at understanding of how we actually individualize, the understanding of the individual people behind this. And this is what I want to briefly explain to you, how we currently make diagnosis in psychiatry. So we have symptom checklists, which are based on international criteria of handbooks, for example, the DSM, so the Diagnostic Statistical Manual, which is used in the United States, but also in Europe, the International Classification of Disease. So they have criteria, and these criteria help us to understand what a patient reports, what behavior they have. And this is an example here for depression, such as weight changes and depressed mood and other things, as you can see here in that list. So this is all, at this stage, what we use to classify someone being depressed or having a schizophrenia or having a bipolar disorder or any other disorder. So I would say it's good to have this available, but it's probably not so good to inform us further about the treatment outcomes. And this is here a slide in this presentation which indicates the survival curve. So what it means actually that patients, how they present over time, with relapses once they had an illness. And what you can observe is here that those which have what we call residual symptoms, so they had an illness but they still have some symptoms, that these are the ones which have the shortest time to a next episode of illness. So in terms of the symptoms which we measure, they don't seem to tell us not all the story. And they do not tell us really these signs and features of the illness about the cause of an illness, and they do not tell us anything about how we define treatment of an illness and the overall cause of the illness over time. Now, looking at the cause of the illness means usually we look in terms of time. So we have time point 1 and time point 2, and this could be a year or 2 years or 10 years or 20 years apart. And we start to understand that an illness can have different episodes, like a single episode here, and many patients with a single episode of depression actually recover from this within sort of the first year, so 60 to 90% of adolescents, for example, they recover from the illness. But then we have also a cause of illness which is a recurrent form, so it has multiple episodes, and a form with full recovery in between, and forms which have multiple episodes, but they do not recover fully in terms of their symptoms and their function between episodes. And then we have a very type of aggressive form of illness where the cause leads to a quick and severe functional decline. So this is something we only can actually understand retrospectively. So this is basically the same type of feature, but for schizophrenia, and it doesn't really matter. It could be any type of other illness, whether it's bipolar anxiety disorder or even a personality disorder. So here you can observe that only a very small proportion of people, around 8%, have actually a single episode only. The rest has recurrent episodes. So that's the problem and presenting to us in mental illness. And we would like to know actually in advance, not retrospectively, what these causes of illnesses are. Because the assumption is that someone with this type of cause of illness would need a different treatment than someone who has a very aggressive form of the illness. And therefore, coming from a more retrospective approach to a prospective approach is a key and a game changer, I think, in mental illness treatments, but also in diagnostic procedures. And this is what I would like to talk about in the next few slides. So we are going away actually from classifying illnesses according to symptoms and signs and what we perceive about the patient in talking to them, to maybe extending our approach in the assessment to include, based on a biopsychosocial understanding of mental illness, to include not only the psychological component, but also physical components, behavioral components, as well as biological components. So we have an integrated approach. And by doing that, the theory is that we are able to then identify different types of groups of patients. And some of these groups, they are maybe patients who respond very well to certain treatments, but not to other treatments. So you would give them a different type of treatment. And that is based on a very holistic and complex assessment in the first place. So this basically leads conceptually to the idea that psychiatry and psychotherapy are actually, or can be, not only personalized, but also being predictive. So it can actually predict not only diagnosis, but cause of illness, functional development during the illness, and also predicting the treatment outcome before you start someone on a certain treatment. And this applies to biological treatments like medications, but also to psychological treatments such as psychotherapy. There are different ranges available there. So before I go into some more detail, I just wanted to briefly introduce our research program. And Professor Bernhard had explained to us that we have different themes here, and here you can read them again, like the personalized psychiatry and even neuroimmunology, but also we span from basic science to clinical research and vice versa. And this is what you will hear in this talk. We have a multi-campus type approach to mental illness research here in the different types of hospitals. The Adelaide Clinic with Professor Sherry Gallatley leading the private hospital. And this is a group here we do some research in the clinical research facility, which is down on North Terrace in the new Adelaide Health and Medical Research and Science building. Now, let's stratify, and this is what we call, this is a key word now in mental health research and probably also in clinical practice down the track, to stratify individuals according to the cause of the illness, to the what we describe as etiology and the mechanism of illness. So treating symptoms, we have learned, is not enough. Treating symptoms means there's a reduction in symptoms that's good and necessary, but it does not change necessarily the cause of the illness. So treating the underlying mechanism and the etiology is important. And I would like to briefly mention that trauma has been a very highly, very important with high impact in media, in the general public, the understanding of trauma, any type of trauma, whether it's maltreatment in childhood or trauma also in combat situations, has given us an understanding that trauma leads to a significant change in various risks for later development of mental illness. For example, alcoholic, drugs and alcohol problems, antidepressant medication, absent from work, other things like suicide. The risk for suicide is 15 times increased for individuals who experience and were exposed to trauma. But importantly, not everyone who is exposed to trauma develops any of this. So there's only around 1/3 of people who develops these kind of things, and with a very detrimental course. Another third has some symptoms but recover, and another third, so the final third, would not, despite the exposure, would have significant problems at all and may not have any problems at all. And it is important for not only for research but also for clinical practice to be able to distinguish these different groups from one another, because they require different types of interventions and treatments. Just very briefly, so these types of exposures with trauma, like maltreatment, have impact on brain function. And this is a study which my colleague Udo Danlowski and I have conducted. And that what it shows actually that the activity in the brain and the area which is called the amygdala, which deals with emotion processing in the brain, that has been increased in adulthood in individuals who have has been exposed to some trauma in childhood. And not only their long-lived sort of exposure and the longitudinal consequences of this have been shown here, but also in brain structure. So the hippocampus has been actually decreased, so has been shrinking over time and has maintained that shrinkage, although the trauma was like 20 years and more ago in the past. So this indicates there's long-term impact, and we call this limbic scars, because it's a limbic system in the brain which deals with these different experiences. And this is something similar which indicates, again, even in healthy individuals, so who have no mental illness but have been exposed to some trauma, that although they don't have a mental illness, but their reactivity in the amygdala to negative phases, like 20, 25 years later, is more negative, more strongly expressed than in individuals who have not experienced trauma. And we've shown that also at the biomarker level. So when you take a blood test, you can actually measure certain proteins. In another study, this is a study in individuals who were depressed for many years, and we looked at their exposure to childhood maltreatment and measured in the bloodstream in adulthood the levels of inflammatory markers, so of markers which indicate some level of immune change. And we looked at these markers, interleukin 6 and tumor necrosis factor alpha, and found that individuals who had been exposed to sexual harassment in childhood had increased levels of these inflammatory markers in adulthood. Although there was maybe a year or 2 years of exposure 20 years ago, 30 years ago, they still had that exposure, that marker of inflammation in adulthood. So this has implications really in long-term biological changes. And there was also, as you can see, a dose-response relationship. So the more sexual abuse there was, the higher the level we had found in these inflammatory markers. And this is something which we also can understand better from a mechanistic point of view by studying animals, and small animals, in this case mice, which we do here in the University of Adelaide, and looking at these different exposure mechanisms and what actually changes in mice behavior. We could, for example, show that mice who were exposed to early life stress, that these mice had increased anxiety behavior, but also had increased depression-like behavior, so helpless-like behaviors. And these are, when you see these pictures, we had different people in the group and who deal with these types of research. Now, what's been often discussed now, that the mechanisms by which these behaviors are mediated are related to genetic function and to modification at these genes. So we looked at what we call methylation, so which changes the activity of the gene itself in these mice. And we found, for example, that the stress response receptor, so the glucocorticoid receptor NR3C1 has been changes in methylation, and therefore changed also the expression, and this is shown briefly here. But also found that exposure to chronic mild stress and early lifehood changes in these mice were actually related to immune changes in adulthood. So this is a change in T cells, so a certain type of the immune system, which indicates an immune suppressive effect in these animals. So what that basically shows is that we have, through some exposure, we can subgroup these individuals by looking at their biomarkers, for example, and their brain markers, because there is a change there, even if the behavior appears still to be normal, and we can understand the mechanisms, the underlying genetic mechanisms behind this. And here is, so this is another area which is really important to understand, because a subgroup of patients which we deal with, and this is regardless of diagnosis, seem to have a change and how should I say this, sort of a deregulation more broadly in the immune system. So what happens in the immune system, and Gaurav Singhal has worked on this during his PhD and otherwise, so it's very, very important work, I think, here to mention, so that the immune system in the periphery, so when there's inflammation, such as through infection, but here through psychological stress, that this change in the immune system impacts on the brain. And these brain activities, these brain changes, are relevant for the cause and the symptoms and the mechanisms of mental illness. So therefore, and we'll come back to that a little bit later on, we will need to potentially treat the immune system and modify the immune system in order to treat mental illness. Now, another really important form of mental illness is related to medical disorders. And medical disorders, like cardiovascular disorders, for example, metabolic disorders, diabetes, are also important factors which impact on mental illness. And this not only relates to depression, this is a book I've published this year, but also to other across different types of mental illness. So here's a study from 2003 where it was shown that people with severe mental illness they do not die from the mental illness, but they do die from cardiovascular disease as a primary cause of death. And we know already now that people with severe mental illness live 20 to 25 years less long than the general population without mental illness. And this is not because of the mental illness as such, but because of other associated illnesses such as these here, heart disease, cancer, but heart disease is the most striking one, and other cerebrovascular diseases. So what that means is that it would be narrow-minded if we look at someone with depression and not consider any other medical illnesses or mechanisms related to medical illnesses. And we have done some work on this and tried to identify shared genes between depression and, for example, medical illnesses here, coronary artery disease as one example, and we found that some genes seem to be driving both illnesses. So here the question arises, are we dealing with two illnesses or are we dealing with one type of mechanism? which is the genetic mechanisms underlying the expression of the two illnesses. And I think that's really important insight for our understanding that we need to go across the diagnosis, we need to go across psychiatric and medical illnesses to understand the underlying causes and mechanisms of mental illness. Now, this leads to the next part of my talk, which is looking at what we call biological signatures. So can we identify a signature of a mental illness and of treatment response, which helps us to actually look into the future a little bit. So looking into the future here means whether when we classify someone and investigate their blood, whether that will tell us something about the cause of illness, whether it tell us something about which medication to choose or which type of treatment to apply before we actually apply the treatment with the aim to increase the efficacy. We have made major changes and advances actually in genetics of mental illness, and on the previous slide you saw just some new discovery we are part of, which discovers more than 40 new genes for depression. Has not been published yet. That's why I'm not talking about much, but it's in the process of publication. The idea here is for personalized psychiatry that we actually are in the position to take measurements. And as I indicated in the beginning of the talk, so far the diagnoses are not really based on any measurements. They're not based on any objective measures. They're not based on blood tests. So imagine you go for a cancer treatment and the doctor asks you, what kind of symptoms do you have? How do you sleep? And then you get certain answers, and you try to, as a doctor, you try to make up a treatment from that level of information without being able to investigate the cancer, without being able to characterize the cancer and devise a treatment based on your findings. Yeah? And we want to get to that level, although it's very complicated and complex in mental illness. It's even, I think it's a big challenge, but I think we need to go that path for a number of reasons. And to understand, like through blood analysis, through brain research, and that used not only in research but also in clinical practice down the track, and other devices which we can use to objectify what patients' problems are and then address these problems in an objective way by devising sort of certain treatments which are tailored to that particular person. So just very briefly, this is, I don't want to bore people with too much technical detail, but just very briefly to say that we start, of course, with the genome. And the genome, then, the individual genes, they're just sitting there, and they can be active or inactive. And what we can measure their activity, basically their expression in the transcriptome. So that's the result of the gene activities. And then what's transcribed then can lead to proteins, and these proteins we can measure in the bloodstream. But also the way it is transcribed depends on sort of changes at the gene chemical level that helps to express or suppress the expression of certain genes. So this is just so very briefly, but we need to look at the different, not only at genes, if we want to measure biomarkers, in order to be able to understand what treatments are useful and which treatments are not useful for patients. So this is a lot of work we do in our biomarker center here, which we started a few years back, and so we deal with a number of different psychiatric disorders here, as you can see, for example, psychosis, schizophrenia, cognition, mood disorders, depression, and other things. We do this as a service to national, international groups, but also use it as a resource to study mental illness very broadly. So Paracelsus, you're probably familiar with Renaissance physicians. He said, once you need to find the right dose of the right treatment, and not just medication, I mean treatment more broadly, and for the right indication, for the right patient at the right time. So this is a lot of, rights and conditions to find a good treatment for someone. So this thinking is not new, but I think, testing urine, for example, which they did before to identify someone with diabetes or not, has been a good advance at the time, but it's maybe not a good idea anymore. So we need to be more sophisticated in the way we approach this. And this actually shows how we should do this. So this is our patient group. They are different, but we treat them at this stage, as if they were the same. Because they are different, we see different outcomes if we treat them. So we have, for example, individuals, and this is what we would like to achieve with treatments, that the treatment is efficacious, so it's helpful, and it is not toxic. And this applies also to psychotherapy, because psychotherapy can be toxic as well. So it's not just always good. But we have other scenarios like being efficacious and toxic, so you don't want that as well, because you want a treatment which is not only efficacious, but want to avoid toxicity. We very often have that in cancer research and cancer treatments, and other scenarios here as well. So ideally, you want to employ tests which single out scenarios you don't want for the patient, and you want this scenario here up here, the efficacy and no toxicity or very little toxicity for the patient. It would be very nice and easy, and in the New Yorker in 2000 there was an article with a little article which describes this. So the sequence, the genetic sequence of an individual would be on a script or on a USB stick, maybe we would say these days, and they would go to the pharmacist and say, please give me my medication. So they wouldn't know what diagnosis they have, what problems, they would just get that out of the sequence. I think the idea is simple and attractive. We are not quite there yet, and we're still discussing a lot on these topics in 2017, as you can see from this particular cartoon there. However, the idea is that we combine the clinical information with the biological information, the personal factors, the environmental factors we talked about, and we combine these and put that into what we call algorithms and thinking processes, which are like decision making and decision aiding processes. And that gives us like a prescriber report, and that prescriber report can then be used, to see whether a certain drug, or could be also, I think, extended to psychotherapy, will increase the efficacy of the drug or will reduce the toxicity, or does any other sort of adverse outcome. So this is where we want to be. And a certain advance has been made, for example, with a certain enzyme, the cytochrome P450 and its subtypes, where we have come to an understanding whether certain patients on certain drugs are what we call poor metabolizer or hypermetabolizer. So if they take a certain drug because of genetic modification of these enzymes, the activity of the enzyme then deletes, for example, the activity of the drug. Or very little drug leads then to a high amount of drug in the blood, and it can become toxic. So these situations can be sort of examined already with genetic tests at this stage, and that's been done throughout the world, I think, more or less as standard practice also in psychiatry. And this is Harris Eyre, a PhD student of mine, an ex-PhD student of mine, who is now an entrepreneur at the University of Texas in the United States. And he started, as an example, a company which looks at understanding the genetic testing, like cytochrome P450, but also other enzymes, and give that test to patients in order to get a prescriptive report, which helps us deciding on what to do. So there's lots of activity in the market there. I wouldn't say that all the activities are good activities, but I listed here some which are probably one of the better companies in that area. Now, treatment response to a drug is very difficult to predict, even from a genetic point of view. So this is here you can see this kind of gray figure, which is called Manhattan plots. This is an outcome of a genetic genome-wide association study. So this is not very appealing, and in fact the results were not very appealing either. So we investigated whether patients with depression received SSRIs, so serotonin reuptake inhibitors, whether they responded to the drug or not, and whether that response could be predicted through the genetics of the genome-wide, so all genes considering like 25,000 to 30,000 genes across the genome. And here what we found is there is no particular gene related to that treatment response, so we couldn't use it. But what we could find is, and investigate further, that other traits, other biological and medical psychological traits could influence their treatment response. And here is an example for medical comorbidities, and we've shown that in clinical studies that patients with medical comorbidities and depression have poorer treatment response to these antidepressants than those individuals without medical comorbidity. And we investigated a bit further and asked the question whether we have a shared genetic background for treatment response, not only related to a drug, but also related to other more complex genetic traits. And this is Asmira Amare, a PhD student in our group who investigated a bit further. So you're probably familiar with the term lithium. Lithium is a salt, basically, that was discovered by John Cade and then further refined here in Australia, and it's one of the most effective treatment for bipolar disorder. For patients who have depressive episodes and manic episodes, quite the opposite, that type of treatment seems to be very effective in around sort of 1/3 of patients. But this bipolar affective disorder is defined by clinical signs and features, as I talked about early on. So we wanted to know whether other genetic traits in bipolar disorder, like schizophrenia type genes, associate also with the treatment response. And through this work, which was just published in JAMA Psychiatry, which is a top journal in psychiatry worldwide, it was found that the schizophrenia load, so the genetic load with schizophrenia genes, would predict failure to treatment outcome to lithium treatment response in bipolar disorder. So the patients who had a lot of genes, so to speak, which are associated with another disorder, with schizophrenia, they were the ones who did not respond to lithium. So if we would have known this before they started treatment, you could have prevented a lot of unnecessary treatments. Because lithium, as with any other medication, if it's effective, it often has side effects too, or the potential for side effects. And similarly, he also investigated then further on whether genes in depression, so which are typical for depression, whether they would predict the treatment response to lithium in bipolar disorder, and found again that if there is a higher load of genes for depression, then the reply and the response to lithium in bipolar disorder was not very good. So again, here you could see, even without knowing, you could see the problem, but you wouldn't need to classify the patients necessarily according to clinical signs and features, but through these additional genetic tests, that you could actually predict the likelihood of treatment response. So that's really important work, I think, and sort of indicates where the field is currently moving. Something similar we also have, then down the track. So when we start from genes, and we talked about that just in the last sort of 2 slides, to the next sort of gene product, basically, or the gene expression level. And Liliana Cebano, who is a PhD student in our group here, investigates that further for depression in particular. So what gene expression means, what you can do is when you have a set of certain genes, you can compare individual A and individual B and look whether the gene 1 is upregulated or downregulated in those individuals, and you compare them to each other. But what is a little more advanced is to create, so to speak, networks, so that you not only look at individual genes, but you look at a gene network of genes which correlate with each other quite closely. So we're looking at larger patterns, and that's important to understand, that we're not only looking at single genes, but at large pattern of gene expression, of gene networks, which associate then with a disease status or associate then with treatment response. So this gives us a lot of information, and here's an example of an NHMRC-funded study in the elderly, the Sydney Memory and Aging study, where we looked at the transcriptomics, or the gene expression network, basically, for recurrent depression, so for a more severe form of depression. And this is all very sort of complex and complicated. I want to go into details, but this is how one can represent such a network and different modules. So modules means a certain network characteristic is kind of grouped together and is associated then, so the representative of that network, the eigen gene, is then represented and associated with the outcome, in this case with depression. And we found sort of so 4 of these networks being associated, and what you can do, and that's very interesting as a next step, you then can look at the specific genes and characterize their function. And here comes again, as an example, the immune system in again. So several of the genes we found associated with recurrent depression are lying in the immune system. So this is interesting, and we could potentially say that there is maybe a biological subtype of an immune dysregulated or dysregulation which predicts then to become depressed or being clinical depressed. And the question is, the big question, should we then treat these patients differently than we do at this point in time? Because at this point in time, we don't have a good rationale for treating people, really. So these are interesting tools, but we can go a step further. And Oliver Schubert is investigating what we call the proteome. So proteomic data means that we look at the proteins, so which are the result of the genes, the gene expression, so the transcriptomic of the genes into protein products, and they can be measured again in the periphery. So what the importance of this is here to say that we not only investigate one marker, but we investigate a whole set of markers, and we want to look at the consistency of these different markers. So a gene, we hypothesize, leads to gene expression and to a certain protein here. And we want to show you an example of how that relates to a phenotype which we think is really important in psychiatry. And this phenotype is the cognitive phenotype. So these are individuals who have had depression, and we look at the course of the symptoms over a period of around 3 years. And what was found that in depression, so depression being a mood disorder classically, it was not the mood which was high up in symptoms, it was actually the cognitive problems which were really very high rating in terms of the symptom severity and the implication patients had. So their cognitive function, their ability to concentrate, to memorize, to have attention, to have executive function, and things like that, they were the problems in these younger adult individuals. So we were interested and wanted to know whether this cognitive phenotype would be related to a biological phenotype as well. And Oliver did investigate this with the transcriptomic analysis and found that out of 62 genes, again, so the majority of genes in a certain module here were downregulated in those individuals who had poor cognitive function over time. And the interesting part for that is that it was not just the gene expression, but out of those 94 genes which were found here, also 41 proteins of the same genes could be measured in the periphery. So that means actually that we are up to understand a pathway from the gene to the gene expression to the protein level, which indicates, for example, poor cognitive function in depression. So this describes probably depression much better than any sort of, 2-hour interview within depression, because it's a phenotype substantiated by a biological type. And from this, which I don't show you now, we actually have thought also to start certain immunological interventions to change then the underlying biology of cognitive dysfunction. So this leads me to my next part, and I think what you could have seen in the last sort of 10, 15 slides is that we've come from an understanding of mental illness, which is currently still dominating here, where we use symptoms and descriptions, general descriptions of behavior, of emotions, of thinking processes to classify patients. And that the cause of illness tells us a little bit more, but this here actually does not really give us a rationale for treatments and not for effective treatments. And we moved forward to include other factors and become a bit more complex by integrating biopsychosocial factors here, and you saw some examples for brain imaging when I talked about the exposure to maltreatment. but also biomarkers in conjunction with clinical signs such as cognitive dysfunction in depression, or with depression as a more severe illness. So moving that way and combining that information, that is the next question and the next big frontier. How do you combine these levels of information? And when I started working in Adelaide 2011, in the first sort of 2 years roughly, it was really important for me to develop a concept around this. And together with Scott and Clark and Oliver Schubert, we developed a concept around understanding how we could actually predict the cause of illness. And we'll talk about in the next slide. Scott has certain skills in the prediction modeling, which helped us to further this field around. But what it indicates here is that we need actually, at the time of assessment of patients, we need to not only look at clinical characteristics, but also at brain function. We need to objectively measure the ability of emotion processing, of cognitive function, of behaviors, of social interaction. So you can objectify these things. It's not just a subjective aspect. And thereby, I think we put actually the people first. Because if you don't do that, you don't assess them comprehensively, and you just rely on the spoken word, this is only gives you a glimpse of what's going on. And by doing a more comprehensive and I admit a very complex type of assessment, I think we will understand better what the cause of illness is, but also then we can devise treatments coming out of this. And this is an example here, and Scott worked this out with this modeling on a certain type of modeling, which I don't go into detail now. But what's important is, if you look at the left-hand side here, so this is an individual which has high risk of developing psychosis. They don't have yet psychosis, but they have a high risk. And the question is whether they will develop psychosis, whether they transit into a full psychosis, whether they don't, or whether they have sort of an intermediate risk where they could go up or down in the risk. And we identified through analyzing the literature that if you combine clinical assessment, cognitive assessment, and then also brain assessment, as well as a certain wave, the P300 wave here, which can be measured with EEG in the brain, so electrical brain measure. When you combine these, you become better at distinguishing which way the disease will actually develop. And this is important because if someone has a very high risk of psychosis, for example, or other illnesses, you would treat them early quite differently from someone who very likely will not have any risk of transiting to a full illnesses. At this stage, we treat them at this point in time all the same, because we don't know. Because we don't assess them, we don't have that information. But we have that information actually available, but we don't make use of it. And this is one of an early study which tries to make use of this using a combination modeling basically of clinical, so historical risk, of clinical factors, of biomarkers here. And what is important to know, when you combine certain markers, you want to be able to predict the likelihood that your prediction is correct, which is called sort of the sensitivity here, that someone actually has the disease or has a certain treatment response. At the same time, you also want to be sure that the person who does not develop the treatment actually does not develop the treatment. Does not develop the illness, or does not need treatment for that reason. And here the specificity factor here jumped up from above 70% here when you just looked at historical risk. When you added a certain biomarker, we were very sure to predict that people did not develop the psychosis. And that means that they would not need treatment, because very likely. Yeah? So you would avoid unnecessary treatment. And at the same time, you would also know those who would transit into full psychosis. And this is an example of how that can be done. So it requires the complexity, and complexity in terms of these algorithms has no end. And Micah Cairns here presented, started to look at what we call machine learning. So where algorithms are fed by information, clinical information, biological information, other types of information, and these algorithms would actually learn from each other to have a better outcome in terms of what the diagnosis might be and what actually the treatment might be best for that particular person. And I learned just the other day that in the United States there's actually already practices existing who use machine learning for patients. So when they come into the waiting room, they fill out a questionnaire with 25 items of something, and then that result from that learning experience, from that algorithm through that iPad or any other tablet, would then go to the doctor before they actually, the patient would enter the room. And they would have some understanding already of what direction to take and what direction to discuss. So this level of information, this complexity, can be made useful and can be made available to clinicians and to doctors in the field. And I think that's the important message here we have. Now, in the last part, and that's really important to me as a psychiatrist, is that we translate these findings into clinical trials and clinical practice. And we're quite lucky here in Adelaide to have in the new Adelaide Health and Medical Science Building a clinical research facility, which you see here on the left. And these are all the people working in different trials and in the area. And we try to model now clinical trials, so testing new pharmacological treatments, non-pharmacological psychotherapy type treatments in trial settings so that we can actually use that concept of personalized treatment to show that it actually works. And these are some of the trials here in depression, for example, and also in psychosis, and funded through NHMRC, Faye Fuller Foundation, and the Ramsay Foundation here in Adelaide. So I will just briefly mention two trials. So the PREDICT study, and here we have Celia Fauré and Natalie also Mills showing that we use a biomarker at the beginning of the trial to optimize the treatment. And this is an inflammatory biomarker which we measure at the beginning of the trial, and then they are assigned in a randomized controlled trial fashion to intervention groups with an adjunctive additional agent or to placebo. And what that should show here, we started now the trial and first patients are now enrolled. What that shall show down the track is that a biomarker can actually help us to devise an optimized treatment. That will be the first biomarker study in this area at all. So it's quite exciting that we are able to do this, and we are supported through the Faye Fuller Foundation to do this type of trial, otherwise it won't be possible. And the second example is on the psychological treatment, so the so-called the CERT-D, the Cognitive and Emotional Recovery Training Program for Depression. And Matthew Knight and Lurtzes are working on this. And this actually individualizes the treatment, so the needs for the treatment and the types of treatment before someone actually starts the treatment. So we're not generalizing treatment, we're actually assessing whether someone has certain cognitive deficits, emotion processing deficits, social cognitive deficits, and then modify the intervention according to that particular person. And this is in a randomized controlled trial fashion, and which is kind of quite a challenge in terms of methodology, because we still want to do a higher level research and be publishing that down the track. So this type of approach, so using biological information, using psychological information, by measurement, by objectifying this, by what patients tell us, so that's part of our approach, we will then be able to be in a position to prevent treatments and illnesses, prevent treatments which are not necessary or which are maybe not the right ones, to be predictive of what's better, and this overall leads to a personalized approach. So this is a little bit of a run-through of an area which has big appeal, I think, which is a game changer, which would mean for the mental health services to completely restructure themselves from a wait-and-see approach to a more proactive approach to a measurement-based approach. It will cost more money on the one hand, but it also will save money down the track, and it will help also to improve, people's quality of life. And I think at this stage, I think that's the best, personalized approach you can have, and that is the most person-oriented approach, because we take the person in a holistic way into consideration. Thank you very much for your attention.
Thank you, Bernhard. That was absolutely fascinating. We've got some time for some questions. So, are you happy just to...
I've got bipolar disorder. My mum has depression, my sister has depression, and my mum's brother has depression. It's taken a long 9-year experience to get stable on medication. So this is a wonderful thing. Is it possible that the fact that I have bipolar but the other members of my family have depression mean that we've got slightly different genomes in the expression of the genes that are involved in mental illness?
Yes and no. So I would say probably you have some similarities and some differences. So there might be similarities in genes, and we have come to understand that from large-scale studies, that some genes can actually go across different illnesses. So it seems to be like a susceptibility gene for a severe mental illness. And then there seem to be other genes which are distinctively different across illnesses. And so you probably would have shared as well as distinctively different genes and their gene expression and transcriptomic picture.
Because my initial episode was a depression, and then later I had hypomania. So that's when I was diagnosed with bipolar instead of major depressive disorder.
Yeah. And that's an important point on the cause of illness. So if we would have better instruments like some of these, we probably, maybe there would have been the opportunity to put you with that risk of developing mania into a different category and treating that differently early onwards, rather than waiting for that to happen. Yeah.
I think it's a question back here.
I was just thinking about what you presented in terms of our evolutionary heritage, if you like, and a lot of the trauma you described must have been very prevalent in evolutionary time. And you presented some incredibly interesting maladaptive outcomes from that trauma. And I'm wondering whether there's any biological mechanism demonstrated for a positive adaptive outcome along the same lines.
I think that's a very good question, and the sort of the biological evolutionary perspective also relates to some of the immune changes which we see in people as well. So I think a positive adaptation to trauma and developing what we call these days resilience, these kind of things, they were let's put it the other way around. I think what we've seen in the last maybe 10, 15, 20 years is through increased chronic mild stress in societies that we have decreased the resilience to trauma, for example. And you even don't have to go so far back in societies, where in Europe lots of wars, in Israel still lots of threat. But the level of resilience at the same time is very high through other mechanisms. So I think it's about the balance between the exposure on the one hand and other chronic mild stresses which go on the other hand, and how that interplays. And I would believe that the immune system plays a major role in mediating those effects. I think psychosocial factors, and if you even level out sort of the social factors only, they are probably one of the most important, environmental factors which drive, health outcomes, and I mean health, physical and mental health outcomes. So, of course, environmental changes in terms of diet, in terms of lifestyle, sedentary lifestyle, in terms of physical activity, these kind of things, they not only change sort of the behavior, obviously, but also change the biology. I think there's a very clear link between, for example, exercise and level of neurotrophins in the brain. So the more people exercise to a certain degree, there's higher degrees of neurotrophins in the brain. That's been shown from humans to animal models. So the environment and the behavior actually shape the biology, I think, very strongly. And that is often forgotten. Also, I don't have time to speak in detail, but in psychotherapy, also the type of psychotherapy changes biology. And vice versa, if you change the biology, you change, emotional processing, the ability to cope with certain things as well. So it's an interrelationship between the environment and the individuum at the biological level, where you talk about social determinants of health. And that, I think that's really has been a little bit forgotten, because we kind of think we live in a virtual world with no attachment to environment. We are attached to environment very closely, and you can also observe that wealth, obviously, in societies plays a major role on their well-being, but not always, because wealth, like in the United States, for example, but also in Australia, leads to a lot of obesity as a lifestyle change outcome. And that is actually changing also the biology and the brain function.
Paul. In one of your earlier slides, I can't remember if it was loss of productivity due to mental health or injuries, but the implication was that Australia was one of the worst places in the world, worse than the war-torn nations of Africa and this sort of thing, which seems surprising to me. And I don't know if that's because of underdiagnosis in those areas, or whether they are better adapted to coping with stress.
Yeah. So what I showed was the years lived with the disability. That means that the disability has been diagnosed and actually has been supported by society. Otherwise, they couldn't have lived with it for a long time. And the countries which are relatively high, except Iran, they have a relatively high life expectancy, although the one in the United States is going down over the last 10, 15 years. But in Australia, it means people live quite long with the mental illness as such. And that speaks also to the richness in the country, to the wealth in the country to support people with mental illness. So it's a good aspect too. But on the other hand, it demonstrates that mental illness, if people don't die, they have to live with quite a burden. And that burden needs to be addressed, because usually people don't die from mental illness, but from other factors like lifestyle-associated factors, cardiovascular disease, and other things which we need to look at.
Are there any final questions before we wrap up this evening? If not, I may ask one very quick one.
Yes.
Have we seen an increase in mental illness, given the sort of dramatic change in lifestyle that we've seen with people having much more of a virtual lifestyle than they have historically, with their tablets and their access to the internet and so forth? Have we seen an increase in mental illness related to sort of almost an isolationist type lifestyle with many people?
I think what we see, if you look at it from a balanced point of view, we see that societies become mentally much stronger, much more able and more adaptive. You see those examples, and you see also examples of the opposite, where people become less adaptive, less able to cope with that. So I think we see more extremes. If you look critically at the epidemiological evidence in terms of increase of prevalence, so the number of illnesses in mental illness, it appears to be quite stable. A recent paper which Liliana has also worked on shows actually that for Australia there's not much change in mental illness over the last 10 years, 20 years even. So it seems to be fairly stable, yeah. But the phenomenology, so the symptoms, they change. But we also become better at things as well. So it's kind of a balance, yeah.
Look, I think it's fair to suggest that we have one final question. Yeah, absolutely.
You were talking about the predictive ability and therefore the preventative nature that we're trying to aim at. Is there a possibility then that the assessment will come in the paediatric population in order to then stratify them? Or is it better to then say if there is an immune component, they would wait for that their immune system to be appropriately developed, certain environmental markers to occur? What are your thoughts on that?
I think we do some sort of animal work in understanding that dynamic of early, like stresses and how that influences immune function. And it seems to be a lot of changes occurring during that perinatal, postnatal, adolescent type period before it actually becomes then a more stable system and maybe a dysregulated system. At this stage, I would say it's probably too early to define and intervene at that pediatric type level. And you can also do some harm and damage unless it's a very clearly defined, let's say, immune disorder already visible in pediatrics. And I think then it's worthwhile also looking at mental health prevention very early onwards. So that makes clinically a lot of sense. But we don't want to over-medicalize at the same time. So we know through these information, we don't want to medicalize everyone and going to the doctor and getting their risk assessed. And I think that will stretch too far. Yeah.
Well, that brings us to a close, and I think the prospect of a diagnostic tool to enable us to actually identify those people at risk of mental illness and also to actually maximise the treatment opportunities is a fantastic thing. We thank you for all of your team's work and your work. As a token of appreciation for your efforts,
thank you very much.
From the
Thank you.
From the executive team.
Thanks.